All right, so this series of videos will explore gastrointestinal pathology. We're going to start with the upper system, and then that includes the mouth, the esophagus, and the stomach. And then we'll go into the lower, the small intestine, and large intestine in subsequent videos. In the very first section here, we're going to look at the assessment of gastrointestinal tract disorders, look at the general kind of biomedical assessments in terms of physical exam, imaging techniques, and so forth, and then talk a little bit about how to think about treatment from an integrative perspective. So biomedically, GI disorders are assessed using several different methods. So I think the most obvious would be looking at history, getting a complete history of a present illness with the patient, as well as doing a complete GI physical exam. I'll talk about that here coming up. And importantly, in the assessment process, we're doing differential diagnoses and making sure to rule out any red flag symptoms that would prompt more urgent investigation or therapy. So we'll talk a bit about red flags for each of the systems we go through here. Of course, you probably know, but just in case you don't, gastroenterology is the branch of medicine that's focused on the digestive system and all the different GI disorders. So referrals to gastroenterologists are certainly something that primary care physicians will do if there are more complicated GI conditions. In addition to history and physical exam, there are a number of blood tests that are often done in evaluating different GI conditions. So the most common would be looking at whether or not there's any signs of malabsorption. And a good way to check for that would be to do what's called the complete blood count, and that'll check for any potential anemia. That checks your red cells, white cells, and platelets. And if there's any anemia, that's going to show up there. The complete blood count or complete metabolic panel, CMP, will check fasting glucose. If it's done fasting, it'll check all of the electrolytes, protein, as well as liver and kidney function. So that's a very useful test for just assessing general absorption and so forth. So we can think of the complete blood count, CBC, as looking at the cellular components in the blood, and the complete metabolic panel is looking more at the plasma and what's in there. Additional, more extensive liver function tests are sometimes done, especially for the liver disorders we'll talk about, like liver cirrhosis. Sometimes renal function tests are needed. Another big area of study for GI conditions would be fecal studies, and that would be either ova and parasite tests. Usually that's done with 3 separate stool samples. The stool is looked at microscopically for any signs of any parasites, and that would be amoebas, any worms, and then any potential spores. Or a stool culture. In a culture, we're looking for bacteria, bacterial overgrowth. So important to realize that an O&P will not capture bacteria, and stool cultures generally won't be able to detect most of the parasites because they're looking at bacterial growth with those. So those would be some other tests if we suspect GI infections. Common imaging studies that are done would be things like endoscopy, and this is going in especially what's called an EGD, esophageal gastroduodenoscopy. This basically is where a scope is put in, usually through the nose, down the throat, down the esophagus, and it's able to investigate all the way to the proximal duodenum, all the way up to basically the ampulla of Vater, and can see if there's any inflammation, any scarring, and so forth. So this is a common test that we often refer out to as primary care physicians for a lot of chronic acid reflux and things like that, and we'll explain that coming up here. Colonoscopy would be scoping to the other end, and there's different ways of doing that. There's what's called a flexible sigmoidoscopy, which only looks at the sigmoid colon, less invasive, less anesthetic, shorter procedure. But really for things like colon cancers and looking at precancerous polyps, it's important to look at the entire colon, and so that's where the true colonoscopy would come in. X-ray with barium contrast, that's still used. Barium will capture any ulcers, any strictures, things like that. And so that's a fairly inexpensive test to do, but patients do have to swallow the barium. And then ultrasound is commonly used for a lot of things like gallstones. We can check for any masses, things like that. So that's nice because it's non-invasive. You just use the sound waves and readily available. CT scans and MRIs, these are for more detailed imaging, and we'll talk about those coming up here. And then finally, another GI assessment tool would be biopsy. And so that would be actually taking, often through endoscopy or colonoscopy, taking a sample of the intestine and visualizing that. Now I should say with endoscopy and colonoscopy, we can pretty much visualize all the way down to the proximal duodenum and up to the ileocecal junction, but the majority of the small intestine, we do not have scoping methods for that. The only really way to visualize the tissue there is to swallow a little capsule that has a camera in it, and it actually takes pictures as it goes through the small intestine and then is defecated out. And those pictures are then transmitted to a receiver, and that can give you some images of the small intestine, but currently there are no scopes that will go all the way down in there like an endoscope. So in terms of GI physical exam, this is basically, I'll just run through the procedure. So this is one of our major physical exams. We of course have the ENT, ear, eyes, nose, and throat exam. We have the chest exam with lungs and heart and thyroid and palpation of neck lymph nodes and so forth. And an abdominal exam is going to look at everything below the diaphragm down to the pelvis. So basically the patient should should lie on the table. They make sure the bladder should be empty before the exam. Room's got to be warm, and there's privacy, well lit. And this is a kind of exam where patients will often tense up, especially if the provider is palpating really hard or nervously. So be sure, the person doing this is calm. Basically, this is best done with a gown because we're going to need full exposure to the abdomen and all the different quadrants. And patients should be covered with a blanket until the actual exam is done. So just in terms of landmarks, again, going through them, this is very helpful for documenting and writing in chart notes. We, of course, have our quadrants, so left upper quadrant, right upper quadrant, and again, this is patient's left and right. So obviously looking at the paper, it's not left and right. So left and right upper quadrant and the lower quadrants and right lower quadrant. And different organs are in each of these. So of course liver is concentrating over here in the right upper quadrant, gallbladder. We have our stomach, pancreas, spleen over here in the left upper quadrant, left lower quadrant, the common place where we have our descending and sigmoid colon, and any problems like diverticula will show up there. And then appendicitis and whatnot often manifests in the right lower quadrant. So that can be helpful. Again, remember that visceral sensory nerves are not so accurate at pain localization. So the peritoneum is more accurate when that becomes inflamed, but the actual organs, until there's extensive inflammation in the organ, it's going to be hard often to localize that pain. There's a further differentiation into epigastric region, umbilical hypogastric region, and then left hypochondriac, right hypochondriac, left lumbar, right lumbar, and then left iliac and right iliac regions. So that's a even finer differentiation that you might see written in some notes. So what's the general procedure for the physical exam here? Well, the first thing is inspection. So before touching the patient, looking for fat distribution, looking for any potential ascites, that's the buildup in the abdomen. Often what we'll do is we'll press on one side of the abdomen and see if there's what's called a fluid wave, and that would indicate ascites versus that it's just abdominal fat or visceral fat. Looking for any stretch marks, cellulite, what are called purple striae. This is typical of what's called Cushing's disease. So that would be another inspection. Looking at the skin color, any scars, lesions, dilated veins, rashes. Looking for any noticeable pulses of the abdominal aorta that might indicate an enlargement of the aorta, potential aortic aneurysm in some patients, older patients. But that would be something just to look at. This is before we palpate. And then checking for any signs of anemia, malnutrition like pale nails, pallor, wasting, any edema, and then visual inspection of the lips, the tongue, and the mouth. All of that's important as well, and we'll talk about the mouth disorders coming up here. Auscultation is listening, so you actually, before you touch the patient or do any palpation, we listen with the stethoscope, and typically with the diaphragm of the stethoscope, and we're going to actually listen to all quadrants, but usually we can just start with the right lower quadrant, and we're going to be listening for bowel motility. So we should be hearing between 5 and about 34 sounds per minute. And that just means the bowels are moving, everything's good. If there's dysmotility or amotility, there's no motility, which can happen in ileus and different conditions. You won't hear any sounds with the stethoscope, and that's not a good sign. Borborygmi are the noisy fluid rushing sounds that you'll hear with the stethoscope. That's normal. In a bowel obstruction, you often hear a high-pitched tinkling sound. That's as chyme is squeezed through that obstruction, causes repercussions, and that's what you hear there. Adynamic ileus is slowed or actually no bowel sounds, and that can happen after abdominal surgery. That happens in many other conditions, so we'll talk about ileus. Peritonitis, you'll also hear no bowel sounds, and that one's going to be extremely tender, even to put the stethoscope on the belly, and that would be a medical emergency to refer out to. And then any arterial bruits in the mid-abdomen, just below the umbilicus, but also the costovertebral angle on the back, where the ribs, the lower ribs there, the angle they make with the spine. If you hear bruits, and those would be deep sloshing sounds, that indicates atherosclerosis, for example, in the CVA area of the renal arteries, and that might indicate renal artery stenosis, which is a cause of secondary hypertension. And then mid-abdomen would be more aortic, potential aortic aneurysms and things like that. So that's one thing there, is listening, auscultation. Then percussion, and that's where you tap with the finger. So basically you put one hand on the patient's belly, and then with the other you tap on top of that. And we're listening for, in all four quadrants, we're listening for what are called normal tympanic sounds. And that's where you should hear like a resonance in there, and that means there's, some gas and fluid, which is normal. If there's excessive gas, you'll hear a very, very sort of tinny tympanic sound, versus if there's more fluid, more consolidation, maybe a mass, that's going to have less of a tympanic sound. We can also check the size of the liver this way, and I might recommend, just going on to YouTube and looking for abdominal exam videos. Stanford University has what's called Stanford 25, the 25 most important physical exams to know, and they show you the whole procedure there. But you can check the size of the liver through percussion, and we often do that just to kind of get an estimate. Liver, most people should be about 7 centimeters or so in width. And then again, any dullness areas might indicate possible masses or tumors, or if there's excessive fluid, that would be ascites. And then we're going to do light and deep palpation. That's the final part after doing all that. First, light palpation, and it's best to have the patient raise their legs on the table so that it relaxes their abdominal muscles, especially with the deeper palpation. And we're going to palpate all four quadrants. We're going to look for any masses, any unusual sort of sensations. Palpate the spleen on the left, look for the liver. We're going to check the bottom edge to see that it has a smooth margin. And then we can actually, in some patients, especially thinner patients, palpate all the way down to the kidneys, which are retroperitoneal on especially the left side. Going to assess for any guarding, any tenderness. Guarding is when you press in, the patient winces, they flinch up their muscles. Any tenderness, any presence of masses, or rebound tenderness, which is when you press in, let go, and then that's what elicits the pain. That's called rebound tenderness, and we see that in peritonitis of any sort. And then check the CVA angle, especially over the kidney region. That's going to be for a kidney assessment. And we'll do that generally when we suspect a kidney problem, like a kidney infection, what's called a pyelonephritis. And then palpate the aorta with both hands. We actually should see that it's only less than 3 centimeters wide. So you can, in the mid-abdomen, press down in and kind of get an estimate of the edges of the aorta. Then looking for any lymph nodes in the cervical area up in the neck and supraclavicular area. And then usually we don't do this on a standard physical exam, but we might need to do a lower rectal or anal exam with a gloved finger. We go in and we inspect for any masses, any hemorrhoids, any fissures, things like that. And then one additional step would be to use what's called an anoscope, which is a clear plastic little scope. You put it in the anus, you can actually, it pushes the tissue out the side, and you can actually see if there's any hemorrhoids or cracks or fissures or anything like that. So this would all be part of the typical abdominal exam. Again, the last part there would not be standard unless we suspected an anal issue. So that's the overview of the abdominal exam and kind of our biomedical assessment methods. So let me just say another word here about endoscopy. It's probably the most widely used GI imaging test. It can be used both diagnostically but also as treatment, and it uses a flexible fiber optic scope. Again, either put in through the mouth or the nose, and the scope has a little light at the end, and sometimes there's a magnifier there to get a more closer view. Some of the scopes can be fitted for irrigation, for suction, little biopsy scissors at the end, or cauterization even for bleeds are also available. And so there's lots of different attachments that can be put onto these scopes. So we're looking basically at the mucosa for any inflammation, tumor growth, any ruptures, any bleeds, things like that. So common one is the EGD, esophago-gastroduodenoscopy, so looking at the esophagus, the stomach, and the proximal duodenum. Enteroscopy, that's the capsule endoscopy I talked about, where you swallow the capsule, and that allows us to visualize the small intestine. And then colonoscopy is visualization of the whole colon, and then sigmoidoscopy is looking at the sigmoid colon. There is a CT scan, I think MRI as well now, but a CT called a virtual colonoscopy, and that's where they can put together these three-dimensional images of the colon from the scan. And the problem with that is, although it's helpful for visualizing, so we'll see that the precursor to colon cancer are what are called colon polyps, which are benign and then at first, and then they undergo malignant transformation. And it takes about 10 years for those to grow. And one of the purposes of the colonoscopy is to visualize if there are any of those polyps and then to remove them. Well, if you do the CT virtual colonoscopy and you find polyps, you still have to go in with the colonoscope and cut them out. So that's why some argue it's just best to do the colonoscopy. But as technology evolves, there might be some other options there. There is what's called endoscopic retrograde cholangiopancreatography, ERCP, and that's actually able to visualize the bile ducts. They go down to the ampulla levator and then go all the way up the bile duct, and that can look for any stones and whatnot, and actually you can pull out stones in some cases. And then we have proctoscopy, which just looks at the rectum and the anus at the end. Some of these procedures are done using anesthetic. Usually not general anesthetic, but sort of it's an outpatient procedure, and the patient is given something to relax them, usually a benzodiazepine, and sometimes some skeletal muscle relaxants as well, just to help so the person doesn't flinch up too much. So those are some of the common medications used for that. There is a deeper technique, would be laparoscopy, and that's actually a surgical procedure where a laparoscope is inserted through an incision of the abdominal wall. And again, this can be used for diagnosis, things like endometriosis, visualization of an appendix, inflamed appendix, and so forth. And a lot of these laparoscopic procedures now are therapeutic as well. They can actually remove the gallbladder, do tubal ligations, appendectomies, all through a laparoscope. And the benefit there is that you only make a couple of small incisions on the abdominal wall, and the healing is much faster than making a giant incision across the abdomen. So this is kind of the preferred procedure for a lot of those more common procedures like that, like the cholecystectomies and appendectomies. Other imaging studies, plain film of the abdomen can be helpful looking for any fluid obstruction, bowel obstruction. You can look for the presence of gas. Remember, with just x-ray, soft tissues don't show up very well, but you can see gas bubbles and things like that, so that can be helpful. Contrast x-rays are where patient swallows the barium contrast material. Also, there's iodine contrast material, and this can be helpful for looking at any ulcerations, any lesions in the intestinal wall. The iodine contrast can be helpful for diagnosing aneurysms. I mentioned ultrasound, very common technique in addition to the endoscopy, and that's for looking for any liver lesions, lesions in the pancreas, gallstones, very important there. Looking for appendicitis. In the early stages, it's sometimes hard to see with the ultrasound, but definitely later stages, looking for ovarian cysts and aortic aneurysms. No ionizing radiation, it's quickly done, no contrast material is needed. So this is a very popular technique for a lot of GI issues. CT scans would look for appendicitis, would look for abdominal abscesses, look for gallstones, bile duct stones, give you better resolution. This does involve radiation, and depending on where in the body, it can be 100 up to 200 times the dosage of a normal chest X-ray. So this can be a concern. We have to certainly look at upper limits in terms of how frequently we can use a CT scan. MRI, no ionizing radiation. That uses, of course, a strong magnetic field. And we're using that for looking at aortic and iliac artery aneurysms, better resolution on abdominal tumors. It's really the clearest abdominal imaging, but it's the least comfortable because the person has to be in that narrow tube, and you have the very powerful magnetic fields firing, and can be very unnerving for a lot of people. So we usually reserve these for when we suspect actual lesions or whatnot that maybe are picked up on the other imaging tests that we do first. Okay, so that was a bit about assessment of GI disorders, and we'll look at how that applies to specific GI conditions. But let me just say a few things about treatment of GI disorders, and this is really where we're going to think about using the so-called therapeutic order again. So our 4 levels of treatment: level 1, establishing conditions for health, and that would be diet, exercise, lifestyle changes like sleep hygiene, stress reduction, and so forth. Level 2 would be supporting salutogenesis. Remember, salutogenesis are the actual physiologic processes that maintain homeostasis. So supporting wellness, basically. And we do that, for example, in Chinese medicine through the pattern differentiation. So isolating which organ system, and then what's the pattern on that organ system. So we look at our yang, qi, blood, and yin patterns. And that's where we use our herbal therapy, things like homeopathy. Now that's a longer discussion. Homeopathy we can really think of as there's 2 types of homeopathy. One using lower dilutions. That would be up to what's called Avogadro's number, meaning that there are still in those dilutions material particles that theoretically could be measured. And this is actually interesting because a lot of your hormones and whatnot are at these dilution levels, 10 to the minus 9th, 10 to the minus 12th. Basically, Avogadro's number is at 10 to the minus 24. And so what's called the 24X remedy or a 12C remedy, anything under that, like a 6C, 4C, 6X, these would all be what we call low dose, low potency homeopathics, and they support physiology directly. We have good evidence that a lot of these metals and whatnot actually can be very helpful for supporting physiologic processes, and that evidence base is actually building. There are well over 400 studies that have looked at low potency phenomena in that action. Acumoxa therapy, of course, and then glandular therapy. So acumoxa therapy, really a tool we have to support the autonomic nervous system directly. And as we'll see, the autonomics play a big role in a lot of these GI disorders. And then glandular therapy would be using bovine or porcine, usually freeze-dried glands where the hormones have been removed, but we give the gland orally as a way of maybe giving special nutrition to a certain gland. So that's another therapy you might hear about. On a more subtle level, say to support the psyche, that's where we might use homeopathics above Avogadro's number, and this gets very controversial in the scientific community. They would argue there's nothing there, makes no sense, but if we think of water holding a memory, etc., we could maybe postulate that we're affecting here not so much the physiology, but more the psyche directly, the actual psychic energy body, and that would be the Hun field in Chinese medicine. And that's really using potencies above 24X or above 12C. And if you read the homeopathic literature, a lot of the remedies are described from their psyche perspective. So what are the emotional specifics about that remedy? A person craves this, they desire that, they have this feeling, that feeling, and that helps you isolate remedies. That's very difficult in talking about the physiology, damp heat in the liver, for example. And that's, again, physiology is going to be more on this level. Flower essences, if you actually analyze those, you won't find any molecules that are measurable really from the plant substances. They're at such high dilutions. Light and sound therapy, all of these are directly, we can say, support to the psyche. Light therapy is really emerging as something that also has effects on the physiology. So is sound. And there's a lot of interest now looking at red light, green light for pain reduction, like in migraines, blue light for anti-inflammatory effects. Red is more stimulating to circulation, warming improves mitochondrial function. So there's a lot of interest going there. And then we can say on an even higher level, supporting the Shen, supporting our thought body, our mental life, we can use even higher homeopathics above what's called 200C, 1M, 10M remedies, meditative exercises, biography work, and so forth. So I'm not going to focus too much on those, but I just want to put those on the plate here, saying that these are certainly modalities that would all support different aspects of salutogenesis. And then level 3 would be replacement therapies, like if a person needed actual hormone replacement, thyroid replacement or something. And that's going to be less common, but thyroid I think definitely is common, but the other hormones would be less common for actual need for a replacement. And then I'm going to put nutrient therapy in here, and that's using usually super physiologic doses, but looking at vitamin mineral supplementation, fat-soluble vitamins, B12, iron, essential fatty acids, amino acids. These are the common ones that often get depleted in malabsorption conditions like celiac disease or Crohn's. So we'll look at those. We also know there are several nutrients that are specific for the enterocytes, the cells that line the mucosa. So glutamine and then short-chain fatty acids, SCFAs, and specifically butyric acid. This is found in butter. But remember, a lot of colonic flora metabolize carbohydrates into butyric acid or other short-chain fatty acids. And these are a preferred food substance for the enterocytes. In this case, the large intestine. Glutamine is going to be more for enterocytes in the small intestine. There's some crossover, but that's generally the division there. So those would be some specific nutrients that have been explored for different GI conditions. Level 4 would be addressing pathogenesis, so directly addressing inflammation, hemorrhage, scarring, directly addressing tumors, things like that. And this would be referral to primary care or a gastroenterologist or other specialists. And that's where maybe further assessment with lab studies, endoscopy, colonoscopy, imaging, and biopsy would be used. And then there's different pharmaceutical therapies and different surgical therapies we'll talk about for different conditions. So there will be some conditions where it's going to be pretty much jumping to level 4 from the beginning, but a lot of our GI conditions, especially in a integrative practices like acupuncture, patients already have the level 4 therapy. They have a gastroenterologist, and they're going to need supportive therapy, and that's really where the level 1 and 2, maybe 3 comes in. And that's where adjunctive providers can really use that. So we'll look at those, how to apply this for individual GI conditions. Finally, I just want to point out, and this is going to be looking at the stomach, but this really applies. We can really look at stomach as representing the whole upper GI system. That would include the esophagus, even the mouth. So I'm going to put all of those under stomach in Chinese medicine. And so if we look at, for example, stomach yang, this would be really, again, the metabolism of that organ. So we look at the arterial blood flow. So stomach yang deficiency, we'd have less blood flow to the stomach wall or the esophagus. And in the stomach, we'd have less stomach acid, less pepsin, decreased catabolism of proteins. We'd say lack of stomach fire. And there's often associations with what we call spleen and kidney deficiency. So the spleen would be more the pancreas from this perspective, and then kidney would be looking at the adrenal cortex function. So we know that the adrenal steroids actually play into supporting the activities of the stomach wall. And then stomach heat, fire, would be more the inflammatory conditions we'd see like in gastritis, peptic ulcer. And there we often see liver heat, which would really be an overactive bile picture, bile secretion, and so forth. In fact, this condition of liver invading spleen, we can really think of that as bile refluxing actually up into the duodenum, up into the stomach. And a lot of people with acid reflux actually have bile reflux, not acid reflux. And so that would be that heat pattern. Stomach chi would be disturbances of the autonomic system. So either decreased or increased peristalsis, so that would be working with the chi level. Blood would relate to the hormones, for example, pepsin, gastrin, all of those. Actually, gastrin would be the hormone, pepsin is the enzyme. So we can start to see atrophy of the stomach wall and stomach blood deficiency that we might find in the what's called atrophic gastritis, or maybe hemorrhaging in the stomach blood excess. And then stomach yin would be more the mucus secretion microbiome. There's not a lot of microbiome in the stomach except for H. pylori, but there's a lot of mucus. And so mucus deficiency, we're going to see increased ulceration. Again, remember that NSAIDs like aspirin in particular will block the production of mucus in the stomach, and that can predispose a person to ulcers or gastritis. Remember, gastritis is just inflammation at the mucosal layer, whereas an ulcer goes down into the submucosa or even deeper. And then yin excess would be excess phlegm, excess mucus. We might call this, have less stomach acid and so forth. Again, dysbiosis SIBO apply more to the small and large intestines, not so much the stomach. But it was thought that a lot of people with poor digestion actually get what the old herbalists used to call canker, and it was this phlegmy lining on the inside of all the intestinal tract, and you can see they thought that canker sores in the mouth actually came from that. But in Chinese medicine, we diagnose that as a thick white tongue coating, and so that would reflect that overproduction of mucus and so forth. All right, so those are the basic patterns of the upper GI disorder. We'll look at lower GI coming up, but next we'll jump into specific upper GI pathologies.